Let's officially begin understanding 1135 waivers, practical insights for healthcare delivery. This is a critical topic for emergency response and healthcare continuity, and we're glad to have the opportunity to explore it together today. Next slide. This webinar is presented by the Region 1 Disaster Health Response System, RDHRS, in collaboration with the Regional Emerging Special Pathogens Treatment Center. Both programs are funded by the Administration for Strategic Preparedness and Response, ASPR, within the U.S. Department of Health and Human Services. Next slide. Before we move forward, a quick note. The content of this webinar reflects the views of the individual speakers and not the official policy of the U.S. government. The information is for educational purposes only and should never replace the judgment of qualified medical professionals. Just as a reminder, our speakers also have no affiliations or financial relationships to disclose. Great. I'm honored to introduce today's speakers, Professor James Hodge, a Peter Kiewit Foundation Professor of Law and Director for the Center for Public Health Law and Policy at ASU Sandra Day O'Connor College of Law. Professor Hodge has been working with the Region 1 Disaster Health Response System for years, and we truly appreciate his ongoing partnership. My name is Noah Emmert, and I'm a JD candidate and legal researcher at ASU Center for Health Law and Policy. I'll be moderating today's session, and we're grateful to have guide us through such an important topic. Next slide. With that, I'll turn things over to Professor Hodge, who will walk us through the details of 1135 waivers and share today's learning objectives.
Great, Noah. Thank you so much. It's a pleasure to be able to join you all, and good afternoon to everyone. First of all, let me acknowledge, if I may, Noah's more than just our moderator today. She's done a great job with several of the different slide concepts and some of the substance that you're going to see. So thank you, Noah, for all your contributions to what we'll accomplish here today. Later in the program, we'll see Noah again, and she'll be walking us through any questions, any comments, anything you'd like to ask in relation to it. We may have the answers and we may not, but to be sure, we're looking forward to that opportunity as well. Here's what we've got in mind for today's session. So listen, we're going to actually just start off with a brief explanation of Section 1135 waivers. You may come into this specific program with real good knowledge and or practical experience in the field working with these issues. Certainly those who work through COVID-19 know what we're talking about. But you also may have arrived at this webinar without any actual working knowledge of how these specific issues work. You're going to be fine. We're going to make sure you actually get that today so you have a real strong sense of it. But beyond that, we'll be identifying operational benefits and limitations of these specific waivers for healthcare organizations. We'll clarify the conditions under which these waivers can actually be implemented. We're going to outline processes for how you actually go about requesting a Section 1135 waiver, including key steps and required documentation. And then we'll evaluate some real-world strategic uses and values of these waivers towards operational continuity, regulatory flexibility, as well as emergency planning. So let's jump into it, and we do so, first of all, with that general explanation of these waivers. Let's set the stage underlying emergency laws that even make this possible so we can pursue these waivers at the federal level to help accomplish what we're seeking to do, provide the very best quality of medical and public health services we can within the CMS and other constructs during these emergency events. It all starts with law, as so many things do in the emergency preparedness and response context. It's law that's going to define what an emergency is. It'll be based on what we're experiencing within specific settings, be it due to natural disasters, pandemics, terrorism events, or otherwise. Law defines what constitutes the emergency. It will authorize the performance of emergency responses. Law will be responsible for assigning the particular responsibility, that is, for potential or actual harms that could arise. Laws literally create that infrastructure as well for how we're actually going to respond in real time. And so to that end, it's so critical for us at this juncture to understand, as we see at the state and local level across our jurisdictions, but also at the federal level, public health authorities, the type of things that we're after here, the abilities, the liabilities, that is, the immunities that may relate to that, they depend greatly on an emergency declaration at each level of government. Now, internationally, we're not here to discuss what WHO or others may do, but at the federal level, these declarations of Stafford Act or National Emergencies Act, the HHS public health emergency we saw used heavily for years during COVID-19, That's going to be quite impactful. But then also your state or local emergencies can influence or shape some of what and how we actually may see these Section 1135 waivers put into place as well. All right, with that said, this is what you saw during COVID-19. What you saw during COVID-19 was literally every emergency declaration that could have been issued at the federal level done so. It started with a public health emergency. You may remember January 31st, back in 2020, Secretary Azar with HHS issued it. It was followed with a PrEP Act declaration on February 4th, and that's still in place. It's very much still in place because it allows for medical countermeasures to be utilized effectively. President Trump, in his first iteration in office, went then further about 6 weeks later to issue a Stafford Act emergency and then invoke the same day the National Emergencies Act. These are presidentially declared emergency issues, not directly through HHS, and later invoked the Defense Production Act. And there's other measures that were taken as well, but these are the highlights. Why are these so important? Because it plays in directly to Section 1135 waivers, as we'll see. That's what Secretary Azar did on January 31st, as per the picture on screen and as per the red language you see below. What that allows for, although still will require more, is waivers. The type of waivers of specific federal laws or regulatory requirements that can pave the way to specific measures and initiatives designed to provide patient care or deal with public health related outcomes and services effectively. Really, it's about, in the legal front, what we experienced and what we're after during COVID-19 and multiple other natural disaster and other events. We'll highlight some of them during this presentation. I like to call it legal triage because it's what, like doctors do in triaging patients, lawyers are doing and policymakers are doing in triaging these critical, tough issues. It's those efforts among legal actors working with you all in hospitals and public health environments and other specific emergency planning arenas to build a favorable legal environment in emergencies that prioritizes issues and generates real solutions. It's going from the, sort of the eye of the storm to some level of calmness. Now, mind you, it won't resolve all of that, but 1135 waivers do help in this process, as we'll see. So let's get right to exactly how these specific waivers can actually be utilized effectively. We'll get a little more to what the tripping points are, but for sure, we're talking about temporary waivers that HHS at the federal level can use, often working through the Centers for Medicare and Medicaid Services, to relax certain Medicare, Medicaid, and Children's Health Insurance Program requirements or CHIP requirements during emergencies. It's about having an emergency, it's about having a waiver issued, and then it's about providing greater flexibility to healthcare providers, public health workers, and others to get the job done in real time without some of the existing regulatory requirements still at play. What's so critical here is just recognizing the purpose of these specific waivers. And we'll get into this a little bit more in the course of our time together here, but let's be clear on these specific fronts. These temporary waivers ensure considerable amounts of activity are possible. First, that sufficient healthcare items and services are available, that you actually get access to them. The things that you might need to invoke, the things that you might not have, or they're in shortage supply because we're in crisis standards or otherwise, these become available through Social Security programs in emergency areas for the duration of the event. So it's about specific needs in specific areas for the duration of the event, and providers who give those services in good faith can be reimbursed and exempted from sanctions. That's entirely possible pursuant to these waivers. The reimbursement facet's so critical, as we see through CMS, because if you can't be reimbursed for some of these services, providers will be at a loss. The types of Section 1135 waivers issued pursuant to HHS through CMS and otherwise are two major types. Let's talk about each of these here, and you'll kind of see how they work a little bit later in our session. First, there's the blanket waiver. You're not asking for this as a provider. CMS bestows this as in its role, overseeing Medicare. It issues blanket waivers. No request needed. When all similarly situated providers, as per CMS's assessment, require a specific type of relief in an emergency area, you're going to see a blanket waiver issued. It will be posted, you'll be notified, hopefully, or you'll be tracking it so that you know that this specific waiver of these measures has been done. And we'll talk more in just a moment about what sorts of things are we talking about getting waived. The second type of waiver is very important. It's actually the one that's used considerably more than the blanket waiver, and that is individual waivers. You're a provider, you're in a given state, you need something waived through CMS in order to be able to provide the level of screening or treatment or public health services necessary during that specific event. You're going to ask for it, and hopefully in many ways you'll get it, but we'll see what the criteria are for that in just a few moments as well. The origins and expansions of Section 1135 waivers briefly, and let's just be quick on this so you have a real strong sense of how they came about. They come about through the Social Security Act and the specific Medicare Catastrophic Coverage Act of 1988, which adds to the SSA Section 1135. And that specific section is what authorizes everything we're talking about here. It was further accentuated in regards to what we saw with PAPA that was introduced in 2005. And you all know we've seen multiple versions of the Pandemic and All Hazards Preparedness Act reauthorized since then. What PAPA did is clarified the triggers. This is so critical. You remember the slide I showed you on the two different major types of emergency declarations at the federal level, a sort of Stafford Act, National Emergency Act, and a public health emergency? Well, you need both to get these waivers in place. Both of those declarations are essential, tied together. HHS is in control of the public health emergency. President Trump right now is in control of the other emergency declarations. You need them both for these specific measures to fall into place. You saw them used for the first time extensively during Hurricane Katrina. Waivers were used to use hospital transfer rules, provider licensure authorities, reciprocity across jurisdictions, and reimbursement, which racked up to the millions and millions of dollars during Hurricane Katrina's aftermath in New Orleans and other places in Louisiana. So to be sure, those first use was proliferate. And then, of course, during COVID-19, incredibly, as Noah's found and documented really well here in this last box on your slide, we're talking about several 100,000 Section 1135 waiver requests issued and 160 blanket waivers issued. You never see anything like that in history, and hopefully we will never see it again. CMS working overtime considerably to even process that number of waivers. And to their credit, even if some issues didn't go as well as we'd like during COVID, CMS working hard to try to make sure to assess those waivers, as we'll see a little bit later too. So with that background and the good sense of what and how these waivers can come into play, let's talk about some of the operational benefits and some of the limitations of these waivers for healthcare organizations. So first of all, why apply for a waiver at all? When do you know you need to do it? When are you at that moment where you need to seek out a Section 1135 waiver through CMS? Well, first, you're in an emergency, and you'll know that, obviously. You'll know that because we have dual presidential / HHS emergencies that will allow for this. Why do you do it? You're doing everything you possibly can within a healthcare enterprise to keep the care flowing. You're flooded with patients. You've got patient surge. Supplies are limited. Medical resources, even personnel, are limited. And you need everything you can to remove some red tape that would allow providers to deliver that type of safe and efficient care during crises. You'll know it when you're in it, but to be sure, you don't wait for this moment. You plan for it, as we'll discuss here. There are multiple operational benefits to these waivers. They're shown on screen here. Let's walk them through real quick so you have a real strong sense of some of the really significant operational benefits and sides to these. First and foremost, we're talking about regulatory flexibility related to legal requirements. Stuff you can't get around normally. Stuff related to EMTALA, which requires, as you know, screening and stabilization of patients that arrive at your hospital ER seeking emergency services because they have an emergency condition. You don't get around that absent a waiver. Stark law related things about doctor referrals and such that would normally trip wires and implicate Stark law, which can be very damaging, can be waived. You know about the HIPAA privacy rule, all the things it requires you to do within a healthcare enterprise, waived possibly during these emergency events. And telehealth services, which rose to significant prominence during COVID-19, that was only possible through these waivers. That is the only way we got that done. Medicare actually paying for specific persons to get care through telehealth that it would not paid for pre-COVID. That's what and how these things come about as being so critical. But they're also about reimbursement insurance. When you're billing for services delivered in good faith and during these specific emergencies, you're going to get reimbursed. with some potential complications, mind you. It's not reimbursement for absolutely everything, but the path to reimbursement for things you would not normally get, it's going to be there. Providers, as per box number 3 here, get to establish alternative care sites. You can modify your facility requirements. You can streamline your administrative procedures. All of this possible through these waivers without tripping up regular CMS guidance or CMS requirements. So normally you can't receive patients seeking emergency services off-site. You can't push them off the hospital grounds and say, we're not going to take them in. EMTALA would stop that. During emergencies, we're going to allow those ACS type of environments to proliferate, and we did extensively during COVID-19. And then fourth, we can expand access to care through telehealth and remote delivery methods, only made possible, as noted, through these specific interventions under these waivers. So, who are we literally talking about as far as how we actually benefit and see some of these examples come into play? Let's give 3 on screen here. You've probably seen these if you've worked in this arena, but let's be real clear on telemedicine services. We're talking about waiving rural restrictions on telemedicine that allowed Medicare to reimburse for those visits, including to the patient's actual house. The places in which telehealth could be delivered and paid for was only made possible through those waivers. Skilled nursing facilities, CMS waived pursuant to its specific measures. The 3-day prior hospitalization rule for these particular facilities coverage. It allowed emergency transfers without a qualifying hospital stay, and it enabled some beneficiaries to renew their coverage even after their benefits were exhausted. These are all don't do's prior to these type of waivers made possible. In physician services, gosh, we saw a waiver of Medicare requirements that patients have to be under the care of a physician and only a physician, because we saw, for example, hospitals enabled to use other practitioners more extensively to provide care in real time as pursuant to those specific waivers. The limitations are there as well. The moment we think that these waivers are going to be the complete end-all solution to everything we're experiencing during emergency events, trying to provide hospital and other type of services to patients, let's be clear about a couple things. First, these waivers end. They terminate with the end of the public health emergency or the national emergency. Providers have to quickly transition back to standard non-emergency rules. It's like a light switch. You turn it off, that waiver's gone. It's over. When President Biden rescinded the national public health emergency through HHS and other emergencies in May of 2023, these waivers are done. Something else has to happen for you to continue to operate under those norms. And that's continued dialogue that we see through CMS or otherwise. They don't excuse compliance, they excuse compliance with certain regulatory requirements, but they do not protect against liability for fraud or abuse or civil or criminal charges. These waivers are not about doing whatever you need to do in relation to providing healthcare services pursuant to a blanket or individualized waiver. If you engage in fraud or abuse, you charge for things you should not have, or for heaven's sakes, you engage in some level of criminality, don't waive any of that. They apply only to specific federal requirements and not state laws. So you may see that a particular waiver actually allows you to get out from under a provision of EMTALA, a HIPAA privacy rule, or whatever, but those state laws, hey, they can't waive those. Those are in place. You're going to see your governor or maybe your Department of Health potentially waive some of those measures, but that's a separate legal dynamic. And then fourth, subject to rapid changes, these waivers are for sure. They can be frequently updated. They can be ambiguous sometimes in application and compliance. You want clarity. You need it to get out of that sort of legal triage environment that you may find yourself in. These waivers may or may not get you there. It depends, and CMS will regularly make changes, especially to their blanket waivers, as needed. Let's talk about some practical advice, just so we have it to kind of take away. ASTO here has done a nice job of kind of laying out 4 particular critical sort of practical advice, as neatly noted here. First, you're going to want to maintain a centralized log of every waiver you're dealing with during these emergencies. When did it commence? What does it allow? How long will it go forward? Make your best predictions. Talk about who's covered, what sort of specific relief has been granted, and who's under what circumstances are services applicable pursuant to that waiver. This is really critical because it's going to be a game changer, these waivers in place, but you got to know what actually has changed. Staff better be updated and educated on these temporary changes. And this is not something to just throw on staff at the very end. really good emergency preparedness and response actually trains for and practices this and sees just how far a particular staff's ready to absorb those critical changes. You're going to monitor CMS and state guidance for updates or extensions. You see a blanket waiver go into place one day, check it again a few days later and make sure that you are following exactly what CMS may have waived, or that your waiver for your institution is still very much in play and that you're following it. When CMS grants an individualized waiver, it may come with specific conditions or things that are different from what you applied for. You'll follow what CMS has authorized there to avoid any potential problems. And a reversion plan. Make sure to observe key steps needed to assume full compliance once the waiver period ends. It can be quick too. A waiver period can end because the emergencies are gone or because you hit a specific set number of days, as we'll see. All right. We've gotten through a good amount of stuff, but let's now try to clarify these conditions a little bit more under which these Section 1135 waivers can actually be implemented. And I hope this will help a little bit, provide some clarity from what you saw in parts 1 and part 2. First and foremost, let's make sure to hit this target so there's no confusion. The HHS Secretary can exercise a 1135 waiver, may actually delegate that to CMS for guidance purposes, only when these two conditions are met. President's issued a disaster declaration, excuse my voice, pursuant to the National Emergency Act or the Stafford Act, and HHS has determined that a public health emergency exists under Section 319 of the Public Health Service Act. Now, COVID-19 doesn't raise any alarm bells for this. This was in place for months on end, but other events will, like hurricanes or other natural disasters or limited outbreaks of specific conditions. These events may not last terribly long, so don't get married to your Section 1135 waiver for too long because it may end so abruptly. The authority that's so critical here is that when effective, HHS really does have very broad authority. Congress gave it to Secretary Kennedy under these circumstances pursuant to laws passed years ago, and what and how that secretary can actually act in a real-time emergency in an emergency area. Now, that's exactly what these waivers allow for. Authority is, as noted, often transferred to CMS for specific implementation issues like hospital conditions of participation or Medicare or Medicaid billing rules, but Secretary does control those specific initiatives. The scope and duration. First of all, for scope of these waivers. It's not about your whole state, if it doesn't have to be. It may be just about a city or a jurisdiction within your state because of a particular issue that's occurred there. Think a terrorism event, think about a chemical spill, think about a natural disaster that's just hit a large area like Boston or a smaller area like several counties somewhere in Connecticut or Rhode Island. These are the ways in which this limitation comes into play. And areas with greater exposure to hurricanes, tornadoes, and wildfires should especially be ready as needed for these specific events. If you're a coastal community where you have more exposure to hurricanes, if you're in a specific forested community, maybe with greater chance of wildfires, be ready for the types of waivers that you might foresee, again, pursuant to those two prior legal requirements in place. The duration. This is what's critical to note as well. They're going to end, these waivers, at the end of the public health emergency termination, or 60 days from issuance, whichever's first. So we can renew these and regularly will during the throes of an emergency event for more than just one 60-day interval, but it's going to end absent that. So that's for sure one of the things to really keep in mind. This is not a waiver that's going to be in place forever, but it's got a limited terminal period. Some EMTALA and HIPAA waivers are time limited even more so. I mean, we're talking 3-day blasts here. You've got an opportunity to sort of divert your EMTALA-oriented specific patients seeking emergency care for emergency conditions because of the hurricane for a 3-day period, but then it's over. I mean, after that, back to business as usual. So some of those have really limited duration. All right, processes. Let's assume that you're at the verge of needing a Section 1135 waiver. The event you can forecast, it's a hurricane or a natural disaster like fires that you can actually assess an impact may result in these dual emergency events, or it's an outbreak of an emerging infectious condition like COVID that you see what's coming. How do you actually seek out and get these 1135 waivers when you need them? The procedure's kind of neatly laid out. We're going to talk about that in relation to blanket waivers and then individualized waivers. First, for blanket waivers, it's accessible only in geographic emergency zones. You don't need to make a request. CMS or HHS is going to issue it. You're going to be informed of it. You'll be watching for this. If you're in the emergency preparedness arena, you're going to be watching for it. You're going to benefit from it, hopefully. CMS will define how those waivers are used. Not you, CMS will. And it's a good note just to say, expect that type of guidance and authority from CMS. It's going to be beneficial. As noted, 160 blanket waivers issued during the throes of COVID-19, 160 different waivers of things you might have had to adhere to. Otherwise, you're going to see that spelled out, hopefully reasonably well by CMS. It's available when CMS determines all similarly situated providers in an emergency require that type of modification. They got to see it in that geographic area due to that emergency that everybody deserves the same sort of waiver, and then the blanket may be issued, and organizations can benefit extensively from the speed and reduced administrative burden associated with individual waiver requests. So instead of having dozens of hospitals or dozens of counties or what have you seek out these specific waivers, you're going to get a blanket that actually resolves it. That's helpful. CMS, hopefully you'll see, does that in real time. But remember, as we go forward, these specific waivers only are used when compliance with CMS rules. And if that is not possible in that regard, you're going to be back in that triage environment. So be conscientious. We only use these when compliance with CMS rules is impossible due to the disaster or the emergency. Blanket waivers otherwise are not going to be issued. It's going to need that sort of level of attention. So you might find you're more in the realm of needing a individual waiver. There's going to be two major steps to this specific issue, and CMS has done everything it can or it could during the throes of COVID-19 to respond to these, but also to assess the way in which these particular waivers are actually sought. And in doing so, there's two major steps. First, you're going to have those two legal triggers that we already talked about. They're met. And you're going to determine that compliance with CMS rules in one way, shape, or form is just not possible. You just can't do it. You cannot respond fully to the emergency and also adhere to those standard CMS rules. So at that point, step two, going to go ahead and use an electronic mode to the degree to which that's fully available, submitting electronic Medicaid and CHIP request using CMS's 1135 sort of online portal for this specific front. You're seeing a picture of it below there, right there, and it's available at the website that you're seeing on screen. You're going to go to that portal and you're going to document exactly what you need to for the purposes of justifying an individual waiver request. A more detailed guidance on exactly how you actually fulfill that, CMS has done a nice job of laying that out. They actually have a great YouTube video that we've seen that actually walks you through it. I highly recommend, if you have not done that, but you ever think you'll be responsible for seeking out one of these waivers, don't wait for that specific event to arise. Go and test that out a little bit. No, not following false waivers, but just see that process. Check out the video, check out the process through which CMS is laid out on their step-by-step guide, especially if you're the type of personnel at your hospital or public health authority or otherwise that's actually responsible for these particular waivers. The review process, this is exactly the sorts of things CMS is going to look at in real time, often within 24 to 48 hours or sooner, to the degree to which it can. It's going to examine multiple factors. First, is there an actual need for the waiver? I mean, you got to show that. You got to demonstrate it. Do you really need it? Because otherwise, they're not inclined to waive anything. Will the regulatory relief requested actually address the stated needs? Let's say you're stating one specific problem you're having and actually treating patients or monitoring conditions or otherwise, and you're asking for a waiver of something that CMS says that's actually not going to help fulfill what you're after. Oh, they may retort back to you that you've sought the wrong type of waiver. Maybe there is a waiver of a particular Medicare or Medicaid requirement you're seeking that would work better, but to be sure, nail it in relation to the type of restriction that you're trying to get out from under to succeed with these specific requests. They're going to look at the expected duration. How long do you actually need this? If they only need it for 3 days, you're only going to get it for 3 days. If you need it for longer periods of time, they might have put timestamp limitations on that. Should the individual or blanket waiver apply? You may see that your individual waiver is rejected by CMS because a blanket waiver already covers it. And if that's the case, great. You probably got the answer you were seeking. You don't need to do anything more. The blanket waiver is in place and you can rely on that. Number 5, can this issue be resolved under current regulations? This is a nice way of saying that if CMS determines that there's actually a regulatory fix for this that doesn't necessitate a waiver, they're going to probably give that back to you and say, you think you need this waiver, but you really don't because we have a regulatory exception in this particular realm. Go for that, use that. We'll find that perfectly agreeable. And you better fit as per number 6 within the emergency area. You don't get to claim these waivers when you're far afield from the emergency itself, unless you can sustain that that emergency may have impacted you directly because of perhaps patient surges that occur outside of a particular area. Otherwise, you need to be within the emergency area through which the public health emergency and national emergency were declared. So a lot of times you may be asking, why was a particular waiver denied? COVID-19 gave us a strong sense of some of this. And let's take a little bit look of what we learned during COVID-19 in response to these types of waivers. As noted at the top, most waiver requests were denied, not because CMS was playing hardball. They were already covered in blanket waivers. I want you to see it for what that is. That's a lot of hospitals and others failing to fully appreciate what blanket waivers were already in place and still seeking individualized waivers, unfortunately taking up some of CMS's time with it when the blanket waiver would have applied. So CMS at that juncture was denying those waivers just because it was able to easily say, we've already got you covered. Others were denied, though, because they involved actually waiving regulations that are critical to patient safety, such as like testing fire extinguishers or scheduled maintenance for infectious control utility systems that weren't necessary. You do not want to waive those specific measures when they're critical to patient safety. These are not the sorts of things that you'd see CMS regularly endorsing or seeking or wanting for that purpose. A lot of exemptions were denied for staff being administered the COVID-19 vaccine and for modifications to Medicaid through the different adult training programs and treatments. I love what we see here. Noah's provided a great image on screen here of all the different types of waivers processed by percentage type, the ones that were approved, the ones that were denied, some of the ways in which you actually can see how many different things arose in the throes of these specific events and the volume of what CMS dealt with during COVID-19. I'll tell you straight up, we all hope we do not experience another event anything close to COVID-19 in the United States anytime soon. It is unquestionably a bellwether event. But what we learned during COVID-19 is to the speed and the need for particular responses and the extent to which these waivers can make those critical differences, that learning will continue for a generation to come. So the CMS's expectations for the waive providers, first of all, at the request stage, literally provide sufficient information. CMS needs it. They've got to receive the right amount of information for those purposes of providers to be waived. When you're utilizing the waiver, maintain thorough and accurate records of the beneficiaries receiving these services to guarantee proper reimbursements. This is not about getting a waiver and simply saying, great, we're just going to continue or start doing what we wanted to do. This is about really good documentation to make sure the ways in which that waiver were used for the benefit of those patients seeking that reimbursement for this care that normally you couldn't do. Yeah, you document it well. And then when you return to normalcy, resume compliance immediately, as soon as you're able. Don't have days or weeks go by where you're still following the precepts of a waiver when CMS and HHS cannot back that up any further. You might lose reimbursement or worse, find yourself in penalty mode, which is not a good place to be post-emergency. All right, let's take a brief opportunity now. I'm checking our timing. We're doing great. And just as a reminder, using the Q&A function, if you'd like, in regards to questions, go ahead and start funneling them to Noah. She's going to be monitoring for that as we finish out our sort of substantive program here. We'll look forward to questions and comments to the full degree we can try to answer them. Let's, in this last segment, evaluate real-world strategic use and value of these waivers towards operational continuity, regulatory flexibility, and emergency planning. Let's just take a glimpse into this just to have that final way to cap the program well and give you a strong sense of how invaluable these waivers can be. So, waiver request during COVID. Here's the top sort of requests that were received. What people and hospitals across the United States sought in regards to these specific waivers. And a lot of it extends from stuff I bet you all experienced during COVID-19 to the degree to which you were in the business that you are now for those purposes. Look at these type of provisions. First of all, Part A or B provider locations for billing purposes. Could you waive some of those measures so we at least can make sure that if we don't have these specific persons in particular hospital settings that are typical for CMS, or we're using provider or Part B providers providing telehealth and other services in non-traditional ways, or even at home or what have you, lots of waivers for that purpose. Waivers allowing for home health agencies, timeframes for OASIS transmission, or minimum data sets to be utilized. Tons of waivers issued for that. The conditions of participation, extensive waivers utilized during the throes of the emergency for what conditions participation can be waived temporarily to allow more providers to provide more care to the burgeoning level of patients. We saw alternate treatment sites and TALA-related waivers, life safety code, the skilled nursing ones we talked about earlier, the thousands of waivers requested on these types of measures give you a strong sense of just how much those played in to effective COVID-19 responses for not just COVID patients, as we know, all patients and all persons dealing with specific issues because of the pandemic itself. Now, beyond the pandemic, though, some other real-world examples do give us a little stronger sense of just exactly how beneficial these waivers can be. Because the next event you experience, as noted, is not going to be COVID-19, we hope. It might be that hurricane. It might be that earthquake. It might be something that's a terrorist event or otherwise that's got a temporary tag on it, but these waivers can be important, like during Hurricane Harvey, impacting Harris County and Houston and other places in Texas in 2017. Hey, without the waiver, hospitals were required to screen patients at their ER campuses as normal. That's a problem. We got lots of patients that have been displaced. We got tons of people that have been unmoored from their homes, and some of them experience emergency conditions. So with the waiver that was put into place, patient relocation in hospitals were able to establish alternative triage in tents next door to the hospital in places otherwise set aside for that type of screening. Entirely possible with the EMTALA style waiver. Rigid billing and transfer rules contributing to delays and claim denials, not good. We don't have time for that during the throes of a 30-day sort of emergency response to Hurricane Harvey. So the waiver allowed flexibility. CMS got to reimburse out-of-network emergency providers that normally can't treat those persons in real time, got emergency exceptions. They got paid to provide the specific services thanks to that particular waiver. And at the bottom there, patients lacking access to care when local facilities are destroyed or overrun. With the waiver, facilities were allowed to expand their bed capacity and waive specific participation rules. We're talking about more patients getting care in that specific setting for a limited duration. The continuity facets of it are so critical. It really helps facilities operate smoothly. That's the whole idea. Are we going to get it to a smooth level of, what we're seeing on screen? No, obviously not. That's what emergencies do. They take us out of that game. But instead of chaos, we may have staffing adjustments, allowances for cross-state licensure, what we call sometimes licensure reciprocity, or ACS, alternate care sites. Each of these make possible the delivery of healthcare services that can at least do what they can to meet particular patient surges and critical health outcomes. The sort of regulatory flexibility emergency planning comes into play here. The regulatory flexibility for sure, suspending those requirements, reimbursement insurance, improving compliance flow during the crisis, all made possible through these waivers. The emergency planning and preparedness, think of these waivers as a tool for disaster planning. It's a big part of the game, but you need those legal issues in place. But if it is in place, know how to use it, encouraging health systems to plan ahead by mapping out waivers. You don't wait for this specific day when you actually really seriously need these waivers and then start thinking to yourself, what do we need waived? Think about it now, base it on experience you've had from COVID-19 perhaps, but more importantly, understand what other hospitals and such around you may be seeking as well. Highlighting the need for tracking waiver use for future justification, such a good idea. Get the lessons learned in real time and plan them forward ahead within your emergency planning, as we know. Here's a couple key takeaways as we round out our session content. Let's highlight the following. First, remember, these waivers are a temporary lifeline during public health emergencies / national emergencies. that national emergency, public health emergency, could still just be limited to your jurisdiction. If we have a major problem in Boston, we're going to get those tags for Boston. But the reality is you got to have those in place. But these waivers will be a temporary lifeline for sure. They're critical for continuity of care during medical and legal triage. I mean, you got to have these, or else you're shutting down care that otherwise the population would benefit from. You can maintain and must maintain, that is, strong documentation and compliance standards. You don't hold to the standards that you're still required to. Document what you're doing consistent with that waiver. In case CMS will come back asking questions as necessary, you've documented it well. And the lessons learned, as we've highlighted so often throughout the course of our time here together, is from COVID-19, a little play forward. There's a lot of good lessons to be learned from that, and to be sure, don't forget them, build them into your emergency plans as you go forward post what we've seen during the pandemic. I hope that provides a really good sense of how these waivers work, what their limitations are, what sorts of things you may expect, and how you may use them effectively by working through the ideas of them now before that next emergency event. You can always contact CMS regarding questions about the emergency preparedness rule and policies related to these. CMS is open to that via the specific sites you're seeing here. And without further ado, let me turn it back over to Noah to take us through any questions or comments. Noah, back to you.
Thank you, Professor Hodge, for that excellent presentation. We'll now move on to our Q&A portion. As a reminder, please type your questions into the Q&A box, and we'll work through as many as time allows. While we're waiting for questions to come in, I'd like to start with one question that we've received. How quickly should hospitals or healthcare organizations expect CMS to respond to a 1135 waiver request?
Oh, no, that's a good question. I'm sorry if we didn't cover that as well. And CMS definitely is going to be, depending upon the circumstances, considerably more inundated than others. But if it's a limited duration event in a particular geographic area, what we're tending to see from CMS is response times somewhere typically in the 2 to 3 days or faster, depending on how quickly the emerging event has occurred. But to be sure, you're not going to wait around forever for these specific responses from CMS. The approach they take to it is sophisticated. They're going to utilize every method they can to actually get response back to you as quickly as possible. But depending on how extensive the waiver request is, in other words, if you're asking for a lot of waivers and or you're seeking waivers that require considerably more justification, it may be a little more delayed, but 2 to 3 days, I think, would be the outside range of what we consider and suggest based on CMS guidance and or practices we've seen so far. It's a good question because you really do want to anticipate if you have advance notice of hurricanes coming or an outbreak of an infectious disease or what have you. Again, don't wait on the idea that you're somewhat put together a waiver request fairly soon at some point. Have it ready, initiate it, submit it, and then wait for CMS's response, hopefully within due time.
Thank you. Another question that often comes up is about documentation. During a waiver period, what sort of documentation or record keeping should providers maintain to stay compliant and protect themselves down the line?
So critical. Great question to ask, Noah. We hit on it and highlighted it in a couple of the slides about the need for documentation. But, it is important that you actually have a strong sense of the type of things that CMS would be looking for. Again, very specific to the type of waiver requested, and some of that may be retorted back from CMS. We'll need you to track this information. But the importance of maintaining it can't be understated. Providers should track, based on good CMS information, the sorts of following stuff. First of all, what particular waiver have you applied for specific to that effort? What services are going to be affected by the waiver itself? You're going to track systematically the type of services within your hospital or other healthcare setting or public health delivery methods or what have you, the actual services that are affected by the waiver. And when you do that, you're showing how those services are furthermore. Get your patient counts. Get the operational changes documented. Show and be prepared to demonstrate to CMS this is the numbers of patients that were benefited by this waiver. This is how many we, assessed in regards to our EMTALA waiver in this alternate care site. Strong idea. And then billing records. Yeah, you better have those neatly documented. What type of billing records, what type of reimbursements have you sought pursuant to that waiver during the throes of that specific duration event? have all that neatly done so that that person or persons within your hospital can always respond back to CMS later as necessary. Sometimes as they'll check up on waiver status and or seek that particular type of guidance. Documentation is critical here, but don't let it stop what you're doing to protect the health of your patients or population health within your jurisdiction. Do it simultaneously with it, but don't let it basically infringe on the ability to respond in real time. I hope that helps a little bit, and I know CMS has more guidance on its website to that end, but that definitely gets us started. Good stuff. What other questions are surfacing now?
One more question to consider, Professor Hodge. Looking ahead, do you think Congress should amend or expand Section 1135 waivers based on lessons learned from the COVID-19 response?
Great point. We look at COVID-19, it's behind us to a large degree. Obviously, new potential strains showing up, new vaccines showing up, lots of controversy over those vaccines as per our last sort of series of events we've seen over the last few weeks. But the reality is CMS is required to report to Congress regularly on Section 1135 waiver implementation and otherwise. And in fact, in January of 2025, a very authoritative report that we've looked at closely, you and me, Noah, we saw some of this as well in putting together some of this great stuff, was basically CMS's response to Congress about what exactly went right and wrong pursuant to some of the methods utilized for these waiver requests and or approvals during the throes of the emergency. It's an authoritative report. I highly recommend it if you're interested to see a little more of the mechanics that are involved through CMS's perspective under HHS guidance that was largely delivered through the Biden administration during the throes of much of the impact of the pandemic. Obviously, things could be different now. But the reality is, I wouldn't expect Congress to touch these issues. We haven't been able, or nor have we seen any particular congressional effort or sort of legislation introduced to refine these methods or to change the direct Social Security Act authority for these specific waivers as adjusted through federal law over time. But I just do not think we're going to see Congress actually make any meaningful reforms. The report back from CMS was authoritative. It seemed to suggest that many of these waivers worked reasonably effectively and that it was able to respond in real time, largely again during the Biden administration. I don't think there's going to be a lot of congressional movement on this specific front. But to cap that question and answer, just to make sure, yeah, CMS was required to report to Congress. It did. And that report is well worth reviewing if you're interested more in exactly what went right and what went wrong according to CMS for those purposes. Great stuff. Anything else percolating out there, Noah?
Yes, we just received a question. Can you please provide an idea of how many 1135 waivers have been issued post-COVID and for what types of events?
Got it. Now, I don't have those numbers to share with you now in relation to post-COVID as of May of 2023. We don't have those specific numbers, but what we'd be looking for in relation to the types of waivers that you may see are the specific events that you've seen on a natural disaster or otherwise, be it wildfires in California, be it hurricanes that have hit specific coasts or otherwise. You see the coupling of the public health emergency with the national emergency, and to the whatever degree we've seen those two things coupled, those waivers have gone forward. Typically, what you would see within those are the most common and popular waivers that are so essential. The EMTALA waivers, the HIPAA privacy rule related waivers, the things that let you do what you need to do in a very short period of time during those natural events or otherwise, that you'd have a chance to actually respond in real time. But I don't have the actual numbers post-COVID of how much CMS has been engaged in that realm. We obviously have had another major change that we're watching carefully post-COVID, and that is we have another change in administration. So we have a federal government being run obviously differently than what we saw during the Biden administration. We have new directors of agencies at HHS and CMS that are dictating different rules and norms. So we're watching that carefully for that next big event that shows us more of what we'll see. But to be sure, CMS remains in the game under HHS leadership for needing to do 1135 waivers when the legal factors warrant and justify them. I hope that helps a little bit. Sorry, we don't have more data about exactly where and how they've been utilized, but natural disasters would be the most common circumstance.
Great. Any other questions? If not, we can move to the next slide. The next session in this webinar series will take place on October 31st, and we'll explore how integrated healthcare systems can strengthen resilience through coordinated capacity management and emergency preparedness strategies. So feel free to scan that QR code for more information. Right, next slide. Great. Thank you all for joining us today. Please remember to text MEXTAM to 857-214-2277 to record your attendance and claim your continuing education credit. If you'd like to connect further, the contact information and resources are listed here. You can also follow us on social media for updates on future sessions. On behalf of the Region 1 Disaster Health Response System and the MGH Center for Disaster Medicine, thank you again, and we look forward to seeing you next time.
Thank you all. Great sharing this information with you, and thank you, Noah, for such great moderation. You all have a great afternoon. We'll look forward to catching up with you on these fronts soon. Take care.